So, good afternoon, everybody. My name is Kevin Dunn, and I'm going to be talking about an introduction to health data. Can I just check that everybody can see my slide?
I can see them, Kev. Thank you.
And then can I just check that we've got the translator on standby, just in case anybody's struggling with my Black Country accent? Yeah, okay. Great stuff, everybody. So, our world is changing fast and constantly, faster than ever. If you think about it, we're now living in a digital age where everything's done on computers and laptops and smartphones and tablets. And the way that we live our lives is becoming more digital. You just have to think about the way that we shop. We used to tend to go to the high streets, but now a lot of our shopping is done online. The way that we bank, again, a lot of that, your accounts can be accessed online and you can transfer money online. The way that we communicate, it's all text messages and emails and WhatsApp messages. And the way that we book holidays, we used to go down to the travel agents, but now a lot of holidays are viewed and purchased online. And even the way that we navigate, so when I was a kid, if we went down to Cornwall, you'd look at the atlas and you'd work out where you're going and you'd navigate that way. But these days, you just tend to put the destination into a sat nav and that will get you to where you need to. And finally, the way that we socialise, so it's all about Facebook and Twitter and Instagram and the like. And when I joined the NHS 22 years ago, this is what our computer screens look like. So it's very, very different to how they look today. And when I joined the NHS, I didn't look like this. I look more like this. That shirt actually fits me now. So the pace of change is increasing year on year. If you look at the history of innovation and the adoption of innovation, back in the old times, the adoption of innovation was quite slow and the uptake of new technologies was quite slow. So if we go back to the Middle Ages and the hunter-gatherer sort of era, it was quite slow pace. But with the introduction of steam power and electricity, we then had things like the Industrial Revolution. And then we had the first man on the moon and computing and the World Wide Web and the internet. And now it's all about Google and Facebook and YouTube. And we're heading towards an era where we're going to have driverless cars. And you think about the COVID pandemic that we're currently facing, that's only accelerated this pace of change. Now that we see more people shopping online, and I've never seen so many delivery vans up and down the street, but also working from home. Instead of me presenting to you today from the University of Birmingham or the Queen Elizabeth Hospital in Birmingham, I'm presenting to you from home in South Staff. And if you think about how we listen to music, that's changed over the course of time. So once upon a time, you used to listen to whatever was being aired. And then we had vinyls, and that was our first ever real storage device, whereby you could get an LP or a record and you could play music when you wanted. And then we go back to the 80s and we had cassettes. This is my era. And we used to tape the little pips on the back of the cassette, and we used to tape the radio on a Sunday afternoon. And you could copy data from one cassette to another. And we had something called high-speed dubbing. And you could speed up the way that you transfer data from one device to another. And then we had CDs, the compact disc, and that was quite revolutionary because you could go straight to the track that you were looking for, and you could fast forward and rewind quite quickly. But nowadays, music is intangible. Often it's in a cloud or it's on a device, and you can't see it, and you can't touch it, but you can hear it. And change happens because of various reasons, but often it's because markets will change or technologies will change. And that's usually because our tastes and our needs and our wants will change as well. So it comes down to consumer and customer demands. And that has an impact on industries. And if you think about HMV and what's up to that as a retailer. And now it's all about bots and artificial intelligence and these technologies that help us to live our lives better. You've got Siri on your phone and you've got Alexa, and these things help us to organise and to live our lives. But now ordering a taxi, we do it through Uber, and we order food through Just Eat, communicate through Facebook and Socialise, and we're testing out driverless cars. But it comes to the point where you could potentially order some food and it gets delivered by a drone. That is the way that the world is going. And I know that you guys all enjoy embracing these technologies, because this is my journey into work. And everybody sits there on the train, heads down, looking at their iPhones or their tablets. And I'm going to talk about data and information and knowledge. Now we turn data into information, we turn information into knowledge, because these words are often used interchangeably, but they are actually quite different. So we're going to start with data, and data is everywhere. It simply exists, and it doesn't have any meaning. It can be alphanumerical, letters and numbers, it can be sound, it can be graphics. And data is the raw facts before it's been processed. And from data, we get information, and that's when we link different pieces of data together and we organise it, and it becomes more accurate and timely. We present it within a context to the point where it has some meaning and some relevance. So I can look at my watch now and it's almost 10 to 1, and I can look out the window and it's light. So I'm taking 2 bits of data and I'm coming to the conclusion that it must be 10 to 1 in the afternoon, not 10 to 1 in the morning, because I'm linking those two data sources together. And knowledge is what we obtain from different sources of information. It's where we become more aware and familiar, and we have an understanding of something. And it can be gained by experience or education, and it can be theoretical or practical. So here is an example of some data. So we've got data here, which is 4654. And what does that mean? Well, it doesn't really mean a lot to anybody. But if we can try and turn that data into information, so we say that team A scored 46 and team B scored 54, we've now turned those numbers into something that means something to us. And then if we know that the highest team wins, we know now, because of that data and because of that information, that we've got the knowledge that team B has actually won. And that's an example of how we turn data into information and into knowledge. So now we're going to talk about patient data within the NHS and what sort of data is kept about patients in their health records. So all data that's collected within the NHS about patients is kept in their individual health record. And historically, this used to be a paper case note, the paper health record. And a lot of health records now have become electronic. So you see the clinicians with tablets and devices that they can capture and record the information electronically. And the type of information that's kept within your health record is demographic data, so things such as your name and your address and your date of birth, who your GP is and your next of kin, but also information about how you got referred into us or how you presented into us. Things like the symptoms, previous medical history. And when you come into a clinical setting, often it's a diagnosis that the clinicians are trying to establish, and the way to find out what's wrong with somebody is often to do investigations, and all these investigations that patients undergo, all that data from those investigations is kept in their health record, and that can be things like lab results, blood, urine tests, etc. It could be imaging data, so it could be CT, MRIs, or chest X-rays, and any sort of other investigations that are done. But ultimately, we're looking to get a diagnosis. And again, there's data around that particular diagnosis. So we've got international classifications of disease, and we've got staging of different diseases and grading of diseases, and all that information is kept. But when we find out what's wrong with you, the plan then is to treat you. And that's where we do our surgical treatments, or we give you medication or radiation, etc. And all that treatment information is also kept in your health record. And even post-treatment, we also collect long-term follow-up data. So we collect outcome and experience data, because it's really important for us to know how you do long-term. So if you've had a knee replacement, it'd be good to know what your pain score was before you had your knee replacement and what the function was. And then we may collect data afterwards, maybe annually. And data can be stored either in a structured form or an unstructured form. And we use data for various different reasons, but first and foremost, it's for the clinical management of that individual patient. So it's to diagnose and to treat individual patients. So what I'm saying there is often the data that's in your health record is only accessed and used and looked at when you're in front of the clinical team, when you're in front of the doctor or the nurse. But we also use data to conduct audit and service improvement. And audit is quite different to research. So audit, you're measuring against the standard. So it could be an existing standard. So you could look at our stroke patients receiving clot-busting drugs within a certain time frame, or our patients waiting longer than the 4-hour standard in accident and emergency. We also undertake research in the NHS. So we could be looking at is a new type of drug better than the existing one, with a new type of treatment. So for example, is treatment A better than treatment B? And we have to experiment, and we have to collect the data to answer that important question. But data is also used for operational management and statistical purposes. So for example, we look at whether the number of breast cancer cases is on the increase. And analysing data has become a lot easier nowadays, particularly with the introduction of an electronic health record. So historically, and when I joined the NHS, the doctors would say to me, Kev, I need you to go and get 150 sets of case notes, and off I'd go to the medical records library and I'd locate 150 sets of case notes. But now, because a lot of this data is captured electronically, it's automatically stored in a way that can be used and analysed. So behind the front end of the systems is the tables and the spreadsheets. So analysing data has become a lot more easier. But what we need in the NHS to answer really important research questions is big data. We need large data sets. So here is here's something, a study looking at heart disease mortality versus systolic blood pressure. And if you look at the data on 5,000 people, you're not really seeing the pattern. But if we look at the data on 500,000 people, we can then start to see the patterns and the insight that we need into those important questions. But there are always problems with the data. So data is often collected and stored inconsistently. So the way that two GP practices collect data and store it could be quite different. Sometimes the data can be incomplete or it can be inaccurate. And data across the NHS is not stored centrally, it's quite fragmented. So if you did go on holiday down to the southwest and you're admitted into hospital, they generally couldn't pick up your GP record back home or your local hospital record. Access to data can be quite difficult, and it can take quite a long time for that to happen. And often the data scientists are not in the same place as doctors and nurses and the clinical team. And that's what Health Data Research UK is all about. It's really about bringing the clinical teams and the data scientists together so we can make these important discoveries. But there are also risks around data. Data is private and people want their privacy respected. We need to make sure that the data is kept securely and that it's only accessed by the people who it should be. There are risks that we could draw decisions based on incomplete data or inaccurate data. So it might be that, we look at data and it tells us that this is a better treatment for this particular condition. But if the data is not robust and if the data is not accurate, that's where we could run into problems. So there's ethical issues with using data, but there's also issues within the data itself. And then you've got things like Big Brother. People are worried about, who's watching me, who's looking at my data, who's accessing my data. People are starting to get worried that we might be sharing data with insurance companies, for example. But the key challenge is to try and bring all this data together. And what we're trying to do is to harmonise and link all these different data sets from all the different sources of information that we've got access to, whether that's clinic letter or an MRI or some genomic data. But HDI UK, including Pioneer, it's about linking all this data together, and then it's about using these new tech tools and technologies to improve the way that we deliver patient care. And that's what HDR UK and particularly Pioneer is all about. It's about bringing the data together from our different providers and then using technology to help how we deliver patient care on the front line. So here's an example of a project that we're doing at University Hospital Birmingham at the Queen Elizabeth. So it's led by a guy called Dr. William Bradlow, and it's a project looking at hypertrophic cardiomyopathy, which is an unexplained thickening of the heart. It's an inherited condition. It affects about 1 in 500 people, and patients are in different risk groups. So some people are at risk of sudden death, where some people haven't got the condition as bad. But what we're doing is we're developing an algorithm, so a piece of technology that can help automatically group patients by their risk into the highest risk, medium risk, and the lowest risk. And hopefully then we can change the way that we treat this group of patients, because high-risk patients probably need to be seen in the clinic more often, whereas the lower-risk patients that can be seen maybe less frequently and more remotely. The idea is, once we've validated that algorithm on the existing cohort of diagnosed patients, so the people that we know about, it's about, could we then run that same algorithm across the wider electronic health records in Birmingham, because that could potentially identify undiagnosed people. So these are people with the condition that are walking around. And if you think about it, this could completely transform the way that we deliver healthcare. So rather than waiting for people to become poorly and end up at A&E, if we could look at the data and predict that they could potentially have a condition, often then you can intervene early, and that will save money for the NHS but have better outcomes for patients. Here's some work that we were doing with Moorfields, looking at developing a piece of technology that looked at scanning the back of the eye, and the tool itself didn't miss a single case, so we had high validity for that particular piece of technology. And there's other examples, such as looking at pathological images and identifying abnormal cells within the pathology images themselves. And we've been quite busy during the pandemic, so we're developing a number of projects within the QE and within UHB to support the COVID effort. So just trying to come up with a risk prediction model for the positive COVID patients, so that we can prioritise and treat them better within ITU. But there's no other organisation in the world like the NHS. It's the single biggest healthcare provider in the world, and we've got a real opportunity that if we can link all this data together, we will have access to lots of information and lots of data, and that'll help us to improve our knowledge of disease and how we can treat patients better. So we've got a massive opportunity here to really improve the way that we deliver frontline healthcare.